morning, everyone. Today I'll be doing my registrar presentation on orthopaedic manifestations of poliomyelitis. Just an overview of my presentation. I'll go through the definition, epidemiology, a little bit about post-polio syndrome. I'll go through the patterns of weakness, describe a bit about the contractures and the gait disturbances, talk about the treatment options, and go through the principles of fracture management, and finally talk about arthroplasty considerations. So poliomyelitis is a viral infectious disease that affects the central nervous system, leading to acute flaccid muscle weakness. Polio, meaning grey, and myelin, meaning marrow. Therefore, poliomyelitis refers to inflammation of the grey matter in the spinal cord. Polio was first described in about 1400 BC by the ancient Egyptians. And on the right, you can see a pictorial description that appears to be a patient suffering from polio. Polio is caused by the poliovirus, which is a neurotropic enterovirus. Neurotropic refers to the fact that it affects or has the ability to cause central nervous system disease, and enterovirus meaning it's spread via the gastrointestinal tract. The disease is passed on between individuals by the fecal-oral route or by pharyngeal secretions. The virus invades the central nervous system, and this leads to meningitis and myelitis. Viral replication occurs in the anterior horn motor neurons, which leads to cell death and then subsequent acute flaccid weakness. About 90 to 95% of cases are actually asymptomatic, and it's only 0.1% of patients that will develop paralysis. Talking about the epidemiology, so in Australia, there were about 20,000 to 40,000 cases of paralytic polio between the 1930s to the 1960s. The incidence then dramatically fell in Australia and worldwide since the 1960s after the development of a vaccine. You can see in 1988 there were approximately 350,000 cases worldwide, and in 2021 there were only 6 reported cases. It remains endemic in only 2 countries, and that's Pakistan and Afghanistan. Interestingly, there are actually a lot more vaccine-related cases of polio than there are wild-type cases, and there were over 400 cases in 2021. The last reported cases of polio in Australia were in 2007 and 1977, and these were both in return travellers. It's estimated that there's between 12 to 20 million people worldwide living with post-polio sequelae. So a little bit about the vaccines. There are 2 main types of vaccines. The first one is the inactivated polio vaccine. And this is the vaccine that's used in Australia and on the vaccine schedule. It's given at 2, 4 and 6 months of age, as well as 4 years of age. It's an intramuscular injection, and it does not have the ability to cause polio disease. On the other hand, there's the oral polio vaccine. This is a live attenuated vaccine. It's no longer used in Australia. It is cheaper and more accessible in low-income countries, which is why it is still used in the world. But it does have a 1 in 2.9 million risk of causing disease. Post-polio syndrome is characterized by new progressive muscle weakness, often decades after the initial infection. It can occur anywhere between 8 to 71 years after the initial episode. Patients may experience fatigue, pain in their muscles or joints, and new weakness. It occurs in about 20 to 30% of patients who have had polio, and it's a high risk of occurrence if there is severe initial disease, if they are older at the time of diagnosis of the acute infection, and if there's significant recovery from the initial muscle weakness. In terms of the pattern of weakness, it can be anywhere between one muscle group to quadriplegia and respiratory failure. Patients show lower motor neuron signs, and this includes hypertonia, absent or decreased reflexes, or atrophy of the muscles. The pattern is usually asymmetric, and it affects the proximal muscles more than distal muscles. It also affects the legs more than the arms. In almost all cases, there's normal sensory exam, and about 5 to 35% of patients have bulbar involvement, which leads to respiratory failure. 2/3 of patients with muscular weakness do not regain full strength. So patients with muscular weakness from polio develop gait disturbances, and they develop compensatory strategies to allow an upright posture and walking. These strategies may become harmful in the long term, and they become more difficult to maintain with increasing age. The strategies also put their joints at risk of degeneration. So just looking at the quadriceps weakness in particular, your quadriceps are obviously very important for locking the knee to allow you to stand. But when you have quadriceps weakness, in order to lock the knee, you have to have the line of gravity must fall anterior to the knee. And this allows then compensation from the capsular structures, the gluteus maximus, and the triceps. There are a number of ways to achieve the line of gravity in front of the knee. This can be via passive knee recurvatum. It can be from a foot equinus deformity leading to knee recurvatum when the heel is on the floor. Patients can also apply manual pressure to the thigh to give extension, and there can be external rotational deformities of the lower limb. In terms of the hip muscle weakness, if they have abductor weakness, this leads to a Trendelenburg gait, and the patients will have compensatory shoulder swing towards the weight-bearing side. With gluteus maximus weakness, they may develop a compensatory lumbar lordosis, which allows the patient to lean backwards in order to extend their hips. An important thing to note is that their spinal deformities are actually quite important and contribute to balance. Patients with polio develop contractures, and this is secondary to unopposed muscular pull, which leads to tissue contractures. It can be due to habitual posturing, which is due to inappropriate positioning. So if patients are kept in a sort of seated position for too long, they can develop hip flexion contractures and knee flexion contractures. And this can be quite debilitating. The other thing to note that gravity also contributes to contractures. So this is, for example, in the case of a foot drop or a wrist drop. The muscles that are most commonly affected are the calf muscles, the hamstrings, the hip flexors, the pectoral muscles, and the long extensors of the back. The soft tissue contractures can lead to growth deformities in the pediatric population. There are numerous deformities possible, and due to the contractures, it can lead to limb shortening, which results in limb length discrepancies. So part of the treatment is orthoses. These can be used as a prevention of deformity or as a gait aid. There are a lot of different orthoses available, but an example is a knee, ankle, foot orthosis, which is used to prevent excessive recurvatum. You must allow for a small amount of knee recurvatum, as I said, to allow the line of gravity to go in front of the knee, but this should only be up to about 10 degrees. Shoe orthoses can be used to compensate for leg length discrepancies, and you can have things like wrist and foot drop splints. The principles regarding orthoses is that they must be lightweight. You should avoid fixed joints wherever possible, as it leads to increased energy requirements in the gait. And a key thing to note is that because of the muscle atrophy, these patients have increased bony prominence, which increases the risk of pressure injuries. The orthopaedic surgical interventions is a huge topic, and if we went through it in great detail, then we would be here all day. But just some key principles. The goal of treatment is to restore or maintain functional ability, and it is not to gain anatomical normality. Treatment includes things such as soft tissue releases, tendon transfers, osteotomies, arthrodesis, and arthroplasty. A key thing to note here is that by correcting one deformity, you may cause a secondary consequence that could have a gait disturbance. So, for example, if you correct a lumbar lordosis, it may be crucial in the patient with a gluteal deficiency in order to extend their hip. In the patient with ankle equinus, it can be really important to allow knee recurvatum and, as I said earlier, to allow the line of gravity to run in front of the knee in the patient that has a quadriceps deficiency. And the spinal corrections can lead to loss of balance and can change the patient's ability to sit. If you want more detail about the specific treatment options and their indications, I came across this paper, which was published in India, and it's from a pediatric orthopaedic surgeon, and they go through all the different treatment options in quite a lot of detail. And this is just an example of one of the tables from their paper, and this one is looking at the consequences of muscle paralysis and the different treatment options. If you look just, for example, at shortening of the lower limb, you can see that there are options to either lengthen the shorter limb, cause growth arrest of the longer limb, compensate with, say, a shoe lift, and if the deformity is less than 2 centimeters, then it should be ignored. So patients with polio and post-polio weakness are at a higher risk of fractures. This is because there are a number of reasons. One is that they're at high risk of falls due to their gait abnormalities. So these patients have a 4 times higher risk of falling than the general population. They can get knee buckling due to their quadriceps weakness. Because of dorsiflexor and hip flexor paralysis, they may have difficulty clearing their foot off the ground. And because they have limb length discrepancies, this can also increase their falls risk. Another factor contributing to their fracture risk is bone fragility, and this is due to the decreased muscle tone. These patients can actually just have regional osteoporosis in their affected limbs. It has been shown that patients with polio have normal fracture healing and normal fracture healing times, but because of their osteoporosis, they should be considered for anti-resorbative therapy. Looking specifically at femoral fractures and their challenges of treatment, I thought this was particularly interesting because at Western Health we have a huge number of patients that come in with femoral insufficiency fractures. In polio, it can be very difficult to get a reduction in fixation, and the patients might not be able to be put on a traction table because of their fixed flexion deformities. There can be issues with fracture healing due to the less vascular muscular envelope. The paralytic hip is associated with having a small valgus and anteverted femoral neck, and conventional implants may not be appropriate. In the picture on the right-hand side, you can see that with their normal entry point, that they've actually ended up quite posterior in the head due to the femoral anteversion. So regarding your treatment options, if you look at the DHS or the cannulated screws, as I said, you might have to have quite a posterior entry point to compensate for the femoral anteversion. In terms of intramedullary nailing, these patients can have quite narrow canals, which can make nailing quite difficult. It is possible to consider TENS, although, as we know, they have poor rotational stability, and you may need to also have some other sort of splinting. On the pictures on this slide, you can see that there's a patient that had a previous femoral shaft fracture fixed with a plate and a periprosthetic fracture, and it was treated with TENS and a cast. Arthroplasty for subcapital fractures is technically very challenging, and there is an increased risk of dislocation due to flaccid paralysis and muscular imbalance. When plating the femur, it is important to use locking plates as they have a higher pull-out strength in the osteoporotic bone. The plates may actually need to be contoured to the existing deformity, and obviously the disadvantage of this is that there's periosteal stripping and loss of the fracture hematoma. There is also the option to use a definitive X-fix, but these can be relatively heavy for these patients, and if they get pin tract infections, it can lead to further muscular fibrosis and contractures. As patients with post-polio weakness get older, they also develop or can also develop osteoarthritis and require total knee replacement. Just wanted to go through some of the challenges associated with knee arthroplasty. So there can be intra-articular and metaphyseal angular deformities. They can have external rotation of the tibia. They often develop valgus alignment due to contractures of the iliotibial band. There can be bone loss due to the poor bone quality. They have narrow intramedullary canals. They also develop ligamentous laxity. They have genu recurvatum. They have a poor extensor mechanism due to the quadriceps weakness. and they, of course, can have flexion contractures. These patients are also at a higher risk of complications. One systematic review looked at 82 patients, and there was a risk of recurrent ricovardum in 28% of patients. 11% of patients had instability. There was a 7% revision rate and a 4% periprosthetic fracture risk. Despite the higher complication rates, these patients were found to have good functional outcomes following arthroplasty. Moving on to total hip replacement. So patients can develop degeneration in their hips on both the affected and unaffected sides. In the affected hips, they can develop dysplasia due to their asymmetric muscle involvement. The unaffected hips develop OA secondary to increased joint reaction forces due to their gait abnormalities, spinal deformities and pelvic obliquity, overuse, and due to their poor bone quality. This just shows how you can get one mechanism of dysplasia in that if you get an abduction deformity on one hip, it leads to pelvic obliquity, and the adducted hip can actually dislocate. The challenges of total hip replacement include the fact that there can be a fixed pelvic obliquity. In terms of leg length difference, the unaffected hip is often longer, and it can only be shortened so much without causing instability. And the affected hip is often shorter but can only be lengthened so much, otherwise there's a risk of neurological compromise. Patients can also have a dysplastic acetabulum. They can have a valgus femoral neck. They often have narrow canals, and the periarticular muscular weakness leads to an increased risk of dislocation. Again, in one systematic review, this looked at 128 patients, and the overall dislocation risk was 7%. So in summary, poliomyelitis is a viral infectious CNS disease. It has been eradicated in most countries, but there are still 12 to 20 million people worldwide living with post-polio sequelae. They can have quite complex deformities with multiple treatment options. The treatment aims to maintain functional ability. The aging population is at an increased risk of fractures and osteoarthritis, and there are significant operative challenges associated with fracture fixation and arthroplasty. And here are my references. Thanks for listening.